go on to Dr. RAVEENDRA, who's a senior consultant and Shankar Foundation Eye Institute, Visakhapatnam, and anterior segment and glaucoma surgeon. And he has another interesting video to show us. On to you.
No, I can share.
You can share. Okay, go ahead. Yeah.
Already started, sir. Sorry.
Okay, I think it. There was a chance of running of the axis. Very tricky situation. The more we pull, the more likely the zonules will be away. So two-handed technique was used here. After clearing the area and all, making the visibility better with sodium hyaluronate. Those are the fibers that have to be separated. How to do that? I was lucky. Axis got completed. After that hurdle, now the zonules had become weak. This improvisation was necessary because the AC had become deep. I had failed twice with the CTR. Now it was the third attempt, succeeded. Are we home? So many side ports, all have to be sealed. Can be sealed. And that ended the case.
Thanks, Dr. RAVEENDRA. That was a wonderful way of telling us how we should ideally mark. I also do use a lot of iris hooks, but I took this message that marking makes it more symmetrical placement and more idyllic. But one question which I have is, what were you trying to cut? Was it an anterior insertion of the zonular fibers which you cut, or did you cut the rexis with the microscope?
It was the rexis that had run wide, and it was the zonular fibers that had partially separated. Means.
Then why, if the rexis has run away, I don't think you should place a CTR in that place. You should then put a CTS and support it to the scleral wall. No. Runaway rexis CTR is not placed, is what I thought. So that is one.
So that will be consideration.
Yeah, that has to be consideration. Of course, The staining of the vitreous definitely shows that you had zonular laxicity, so
Yes.
that came across well. So any comments from the expert panel? Dr. Ajay, Dr. Sandeep, Dr.
I
Mahipal?
think what you have shown is the Rexis runway, and I mean that is always a risky. But then,
Yeah.
I mean, if you are careful enough, you know that the same area where it has runway, if you try to pull it the opposite way, so that the two ends doesn't, as you are trying to take it from that side, as soon as it, but then it's always a risky that if you are trying to put a CTR in a Rexis runway. But then otherwise, I mean, put in a CTR and putting in the lens.
Yes.
That is, put in the hooks and to
Yeah.
go ahead with the surgery. I think that was commendable.
Wonderful. Yes. Dr. Mahipal, Amrita?
I think it was a difficult case, and all is well that ends well. And of course, it was quite challenging. Small pupil, and then zonular weakness, plus difficult to dilate the pupil. So it was a challenging case, I think. So in the end, it was managed well.
So one small tip that I'll give first thing is that I'll wish to kind of be sure that the Rexis has not run away, as has been pointed out by the earlier expert panel, because you will lose the CTR and it will actually increase the rip that is there. So if you are unsure to some extent that the Rexis is not complete, it could have gone towards the peripheral, but as long as it is complete, if you are unsure, I tie a suture. So I tie a suture to the eyelet and then continue with that in case I have to put this thing, because under those circumstances, you don't lose the ring, because then you add another complexity of having a PCR or the anterior Rexis going to the posterior, having a posterior rent and the ring going in, and then you have to try and retrieve that. So typically, if I am unsure and I still want to put a ring, normally I would not, but if I am still wanted to put a ring, then I'll put from the eyelet the 10-0 suture and then insert the ring, so that if I have to retrieve it, in case a mishap happens, I can easily take it out.
Yeah.
Great tips.
Dr. Ramurthy, Anagha, anything?
I think very nicely managed. I think all points have been covered.
Yeah.
Nice case.
Yeah.
One more point. Yeah, Chitra. See,
Yeah.
this, I mean, yes, dilated the pupil with the iris hooks. But then in this sort of cases, normally I would dilate it a bit more, because normally for a phaco is 4.55 millimeters is enough if you are using. But here I need to see where I am.
Yes.
I mean, where is my Rexis? Where is my, if I am putting a CTR, what is it?
You could have pulled the hooks a little more. Yeah.
6.5 millimeter, where the role of the iris hook is different here.
Yes.
Where other than
Yes. Yes.
Just one point, you were trying to cut those fibers or the Rexis.
No, that was
the cystitome edge. Maybe you could use a micro scissors.
scissors. Yeah.
That would have been more controlled, and you would, because using this with a bent, it may not cut so perfectly.
Yeah, it was not available.
Sometimes if there is calcification, you can use a vitrector also.
Yeah.
Sometimes it doesn't move, so you can use a vitrector to make micro cuts over there.
And putting in a CTR in such a situation, actually, it's a very blind procedure, because cataract also is so intumescent and you're not seeing the edge of the Rexis. So it's a totally blind procedure actually.
And actually, one dictum comes to work here: don't put it too early and don't put it too late. So you could actually time the placement of the CTR depending upon where it is, what the CTR contributed, what it did not contribute. So you could maybe delay the putting in of the CTR if the dialysis is not too great and the cataract wasn't too hard. So that's what the dictum for the CTR is, that don't be early and don't be late. So depending upon your surgical acumen, your skill, and how the surgery is going, you could time putting in the CTR as to when you want to actually put in the CTR.
Thank you very much, Dr. Raveendra. That was a very interesting case you showed and very tastefully showed.